Hello, everybody, and welcome. Thank you for joining us. We're excited to have you with us today for the first session of our webinar series, STAR Center Talks Compensation Planning. My name is Mariah Blake, and I'm the Program Manager here at the Association of Clinicians for the Underserved. Today, we'll be starting off this series with a discussion on the finances of recruitment and retention. We just have a couple of quick housekeeping items to go over before we get there. Like I said, we are the Association of Clinicians for the Underserved. This webinar has been produced through our workforce project, our workforce NCA, the STAR Center. ACU is a national nonprofit focused on the recruitment and retention of clinicians in underserved areas. We do that through projects like our STAR Center project, National Health Service Corps advocacy, and training and resources for clinicians of all disciplines. Supporting all of you doing this great work is what brought us here to this webinar series today. As I mentioned, the STAR Center is ACU's workforce project. We're funded through a national cooperative agreement with HRSA's Bureau of Primary Health Care. Through this NCA, we're able to create and share resources and training opportunities like this for health center workforce staff, absolutely free of charge. If you're new to the STAR Center, I hope you'll head over to our website following this session. Our website is listed on the screen there for you. We're at www.chcworkforce.org. We hope you'll check us out and get to know us a little bit better. We've also included the contact information for our whole STAR Center team if you'd like to get in touch with us individually. My name again is Mariah Blake. I'm listed in the middle there for you. I'll be on the back end of this webinar today, handling all the technical side of things. So if you have any trouble or any questions, feel free to send a message through the chat box or send me an email at my address listed there. It's mblake@clinicians.org. We are recording today's webinar, and we'll send out a follow-up email with instructions on how to access the recording and a copy of the slides tomorrow morning at the very latest, so keep an eye out for that. And you can also access a copy of the slides in the handout section of your GoToWebinar control panel throughout the presentation. We love to help answer questions, so please ask them. We plan to use the last 10-ish minutes of the hour for Q&A. You'll be muted throughout the session, but feel free to at any time jump into the chat or questions box and submit your questions there, and we'll do our best to answer those. No need to wait till the end. And last bit, we hope you'll use this time to relax and have fun and take something back from this session to your team following our presentation. And with that, I'm through my housekeeping bit. We are happy to have Curt Degenfelder with us this week as we begin our series on compensation planning. I know we've got a lot to cover, so I won't take up any more time. Instead, I'll hand the floor over to Curt to kick off today's presentation. Thanks again, everybody.
Thanks, Mariah, and good morning or good afternoon, everyone, depending on where you are. Today is the first in a series of 3 that I'm doing. The next one is going to be on provider compensation philosophy, and then the last one is on incentive compensation programs. There is a lot of material here today. Since it is finance, it is a little numbers heavy. So I'd like to repeat something Mariah said. If you do have questions, we'll leave some time at the end, but it's also great if you can type them in the chat box. I will be monitoring that, and if there's something that's confusing, I'd be glad to address it when we see it in the chat box. Okay, so since we're talking about finance, we go straight to the bottom line, or a health center's profit or loss. And the keys to a health center's bottom line are maximizing the organizational service capacity. That is, with the resources we have, serving the most number of patients, doing the most number of services, and just using our assets to their maximum capacity. Second is filling that capacity. So it's great that we create infrastructure. As anyone who works in a health center know, we have issues of patients not showing up and sometimes staff not showing up. So making sure that we set ourselves up for maximum capacity, and especially provider capacity, and then fill that with patients. The last bit of it is getting paid for what we do. And when you see the revenue composition of a typical health center, you'll understand what I'm talking about. This is not a revenue cycle section, so we're not going to be focusing on that at all, but it's just key to note that that's the end of the line that determines whether or not we get paid. Okay, so I've been working with, a little introduction for myself, I've been working with health centers since January of 1996. I've had the pleasure of working in health centers in every single state, and really a big range of health centers in terms of size, from 1 million to over $100 million of budget. And so I've noticed a few things that kind of, I know we like to say we've seen one health center, you've seen one health center. I feel like I've seen a lot of health centers, and there's many things in common that we can observe. And two of them are kind of very relative to laws of physics. So the first is relative to Newton's first law. A body in motion tends to stay in motion unless acted upon an outside force. A body at rest tends to stay at rest. Basically, what I would say, how this relates to health centers, a health center doing well tends to continue to do well unless it cannot recruit enough providers, for example. And we're going to look at the financial impact of that. So certainly all of you on the call today know we do have an outside force, which is not enough primary care providers, not enough providers of all kinds, lower provider productivity than we used to have, and just kind of challenges recruiting and retaining providers. That's why I suspect that you're on this webinar just trying to, at least for this one, understand some of the numbers. The second one that's relative to health centers is the second law of thermodynamics. There's not going to be a quiz on these, and I don't actually know what the first law of thermodynamics is, but the second law of thermodynamics says the total entropy or disorder of an isolated system always increases over time. And so the way I would say that relates to health centers is a lot of times when I go to the health center, I say, well, why are you doing it that way? And the answer is, well, we've always done it that way. And I will tell you that we've always done it that way, and especially with the way we approach our providers, doesn't work anymore. So we need to keep these two things in mind, even if you've been at the health center a while, when you're saying, well, what should I be thinking about in provider recruitment and retention, especially how it impacts our finances. So this is kind of going back to that first slide of Newton's first law. Generally, I see a lot of health centers, especially since the passage of the Affordable Care Act, in a virtuous financial cycle. That is, they have positive cash flow through, I don't want to say high productivity necessarily, but I'll say good enough productivity to produce that cash flow, and a positive payer mix. So certainly in states that did a Medicaid expansion, they saw an increase in payer mix. But in addition, if we have enough Medicare and Medicaid, the two payers that pay us best, that helps produce positive financial results. This is not a hardcore finance session, but I would say generally, I like to focus more on cash than I do on profit. I know we started with the bottom line. We look at profit, but we also ask, are we getting paid? Is it generating cash? That creates excess cash or working capital. So more money to spend on more things, buying another practice, moving into a new facility, taking over something else, adding new services, buying equipment, anything that helps you expand. And obviously, we have seen, and the numbers play out, anywhere you look, we have seen rapid expansion of the health center program, kind of since its inception, but again, especially since the passage of the Affordable Care Act in 2010. That creates more sites, more patients, and more revenue, right? Revenue being the money that we bring in. which has created an increased coverage of base costs. The way we might describe it in economics is economies of scale. So even if your health center doubles in size, you might give your CEO a raise, but you're not going to hire a second CEO. So in essence, the CEO cost per visit declines, and the organization becomes more efficient with growth. This is definitely not all industries or businesses is this true, but this is one where growth certainly helps our bottom line, and many health centers believe that bigger is better. So when we've got our base costs or our fixed costs that aren't really changing, then that additional revenue gives us money perhaps to make investments in infrastructure to improve quality and efficiency. And I know we think about investments often as, well, we're buying something, we're buying a building, or we're buying, a new piece of software or something. But keep in mind, especially when we look on a few slides from now where we spend our money, most of our investments are in people. So in some cases, that investment is maybe in a new position. So I know that a lot of health centers have, let's say, a director of business intelligence or a chief information officer, positions that they might not have had 5 years ago. I would also argue, as it relates to this session, I would say an investment in provider retention, and really all staff retention, to be honest. But if I look back to when I started in this business 23 years ago, a lot of the philosophy was, well, we're looking for mission-oriented people, and we don't pay much, and so we get a lot of turnover, although we do have some dedicated employees who've been here a while. That business model works less and less well. So one of the investments that we need to think about is investments in compensation or staff that are going to help us retain our providers. I know there's a lot of focus on recruitment. You'll see in some of the following slides that the numbers tell us that retention is better than recruitment. Obviously, if you have open slots, you need to recruit. But what do we need to spend? As we think about our future, we've been focused on growth, and we've been focused on maybe building some infrastructure and adding some services. But if we know that we've got an ongoing provider shortage, maybe the investment needs to be in our provider group to keep our providers. Just to show you the flip side of this, the vicious cycle. So break even or low or negative cash flow from perhaps low provider and low staff productivity, and you'll see why I say that as we go forward. So just breaking even, again, as I reflect back, that was the goal when we first, when I first started in this business, was to kind of break even each year, or maybe even survive, to the end of the week and then figure it out next week. And that doesn't work anymore, because just breaking even does not allow for investments in infrastructure to improve quality and efficiency. Even though the job is getting harder, for any of you who work in health centers, managed care, PCMH, meaningful use, a more enhanced UDS with more information you need to report, HEDIS, all of this type of stuff really creates a lot more work for the health centers. So saying we're going to do it in the exact same way is very challenging. Oftentimes, then that leads to inadequate pay and or no raises. So, or raises that don't keep up with the market. We know that provider salaries are increasing at a rapid rate. And unlike other positions, let's say a primary care provider, a family practice physician, working from one place to the next, maybe have to learn in EHR, but caring for diabetes is a skill that's very transferable. So I think that providers certainly are mobile, have mobility in their ability to move around, and certainly the compensation is increasing quickly. So if we're not keeping up with the market, and again, this is going to be a major topic of discussion for our next webinar, that compensation philosophy. We may be, if we go to the next one, this is spinning around, have high turnover or a high vacancy rate. So what I'm going to try to do in some of the next slides is show the cost of turnover and vacancies. Obviously, this is not something that you see in your financial statements. There might be a line item for rent and fringe benefits. There's no line item that says cost of turnover. But I assure you there is a cost of turnover. I assure you there is a cost of provider vacancies that is both missional and quality and disruptive to the operations, all of the above, but also a financial cost. And so we need to recognize that financial cost and figure out how we can avoid that. Thus, that high turnover and high vacancy rate leads to lower efficiency, inadequate coverage of those fixed costs we talked about before. So, creates a real problem, this negative cycle. So one of our goals in provider retention is never to get in that negative cycle. If we're doing kind of okay now, just maintaining that where we are, let's say we have a 1% profit margin, just maintaining that is difficult enough. So we need to plan, and we can't say, well, everything's going to be status quo, and then we just need to tweak around the edges. Again, with the provider shortage, we need to put effort and maintenance into just keeping what we have. Sorry, folks, there's always a little lag on the slides from one slide to the next, so I'm trying not to. Okay, so let's look at our health center sources of revenue. So I want to be clear and how this relates to our providers. Yes, many of you have a 330 grant. Yes, many of you may be associated with foundations. Yes, you might get donations. Yes, you might have a contract with the county. But for the most part, our revenue and our cash that comes in the door comes from patient service revenue. Seeing patients, providing a service, recording for the service, billing, and collecting. That's where we get the lion's share of our revenue. So sometimes I hear, when we're talking financially and, issues, some of these issues I'm going to talk about, I hear this comment, well, doesn't the grant cover that? And the grant may cover that, right? The grant, helps us, serve the uninsured and provide a lot of services. The grant revenue is generally fixed, right? So the more patients you see, you don't get more grant revenue. I guess the less patients you see, you don't get less grant revenue in the short term. If you're not meeting your HRSA patient target, over time, that might have a grant revenue impact. But really, a grant is kind of like supplemental income, and we make our bottom line, our profit or loss, our cash from seeing patients, from billing, and for collecting them. So, it's very important to note when we talk about this, providers, and, I'll tell you straight out, your CFO is not the one who makes money for the health center. It's the providers, right, by doing service. So that's why, provider shortages, or if we have issues with our providers, our bottom line is very, very sensitive to that, because most of our revenue comes from there. Here's a sample. This is not necessarily the way all health centers work. This particular health center has a large 340B program, and as most of you know, there's some issues and maybe threats for 340B, but you can see they have Medicaid fee-for-service, Medicaid managed care, Medicare, commercial, self-pay, and family planning, and about 5.4 million of their 7.4 million comes from that patient service. Again, the 340B is related to patient service or bringing patients in. But you can see while the grant dollars are significant, the major dollars come in from seeing patients, from billing for those patients, and for collecting for the services. So I want to make very, very clear to all of you on the line who are maybe not necessarily in finance, the importance of patient service revenue. Okay, the other thing I hear a lot about, and I just wanted to address it here, again, it's not the focus of it, is, well, what about pay-for-performance revenue? And the way people are talking about it, one would assume that, health centers are getting showered with millions of dollars of pay-for-performance revenue. I would say that's not what I've seen. So I look at a lot of health centers' financial statements, and maybe back in 2010, if you look, and this is not, this is not from UDS data. This is not a survey I've done. This is just, kind of what I've seen in aggregate. That maybe 45% of the revenue came from Medicaid, and maybe 19, and it varies state by state, health center by health center, but this might be a typical health center. 19% from other patient service, 36% from grant and contract, and 0% from pay for performance. If we move forward to 2018, you can see, especially in those expansion states, even in non-expansion states, the Medicaid number has gone up. The other patient service revenue has gone up more slowly. They've added, but again, Medicaid is what seems to have grown the most. Grants and contracts as a percentage of total have declined. That doesn't necessarily mean that they're getting less, but they're just, since the other patient service revenue has grown. And maybe for health centers, pay for performance is 1% of revenue. And then looking forward 5 years, maybe by 2023, that might be 6% of our revenue. So I know there's a lot of discussion on, getting paid for quality and reducing total cost of care and kind of population health and patient management. All that stuff is great. All that stuff probably benefits the patient, but all that stuff does not produce a lot of revenue, I want to be clear. So when we talk about this, we're still very heavily in the more visits you do, the more revenue you get. Now we're going to look at the very end of the presentation of the impact of alternative payment methodologies, which exist in some states and have been proposed in a number of others, that really kind of address this revenue issue, as well as potentially address provider shortage issues. So I hope you find that interesting. Okay, expenses. Expenses are, we're a service business. Our expenses are people, right? So between our salaries and contracted staff, and again, this is just an estimate on my part, between kind of half and 2/3 of our costs. Our people, clinicians, might be around 1/4 of our costs. And again, this varies from health center to health center. Fringe benefits on top of that, right, are another biggest expense for many health centers. Are their second biggest expense. So the first being salary, the second is fringe benefits. So we got to recognize that our costs come from our people. And that's not. I'm not saying there's anything wrong with that. I'm saying it's just important to recognize. We talked about the revenue side. Now, to complete our story to the bottom line, we need to talk about the expense side, and our expenses are people. Again, this is just a sample. This health center, if you can look at the 5th and 6th lines, they use some medical consultants and contract outside for a fair amount of their staff. So, you know, it's also, you know, something that we need to count, but recognizing that when we talk about that compensation, it's all compensation. It's regular staff and it's contractors. Again, in this session, we're mostly talking about employees or maybe direct contracted, but these are how our expenses, and this is not how every health center looks, but this health center is also not atypical in terms of our costs. So our costs are, you know, we do have costs of medical supplies, we do have costs of other consultants we're using, of rent and those sorts of things. But again, our big cost here is people, and that's certainly the way that what you would see at most health centers. Okay, so thinking about provider turnover. So when we lose a provider, there's a loss of revenue for an open provider slot. We're going to have a slide on that, right? This is not a business where others can pick up the slack. Most of your providers, if you ask them today, will tell you they're overworked and they can't see any more patients, partly because of all that other work that goes along with seeing patients, and, you know, for a variety of other reasons. So we don't, if you look at, to read the newspaper, sometimes you'll read that, you know, this big corporation cut 7,000 jobs to save money, and that's going to improve our bottom line. In a service business like us, like a health center, typically when you cut staff, revenue goes down as well. And we're going to look at that and look at that impact on the bottom line. So we're going to lose revenue when we have an open provider, you know, a vacancy where we don't have a provider. There's a cost to recruiting a new provider. And we're going to look at a slide on what that cost might be in a great tool that the Association for Clinicians of the Underserved developed to help you analyze this. But again, not a cost that necessarily shows up on your financial statement, but definitely a cost of turnover. Access to visits may be limited. So this might be more more missional than financial. Access is important to us. That's a goal for most of us. You know, we're in, you know, as the name of the organization implies, communities that are underserved. So when we're down a provider or two, the community in a way is even more underserved. Number one. Number two, maybe it takes longer. You know, maybe we'd like to bring in a patient in 3 days, but since we don't have enough providers, there's not enough appointment slots, and we're not able to bring that patient in for a week or two, something like that. So definitely limits access. Provider continuity with staff is interrupted. So if we turn over providers, or quite honestly, if we turn over medical assistants or nurses or LVNs or whoever it might be, then that working relationship gets interrupted. And if you look at providers who've had their support staff for a long time, they tend to be more efficient. You know, the support staff knows what the provider wants, and the provider knows what to expect from the support staff. Maybe they're even good at understanding each other's notes, right? So we talk about continuity of care. I would say continuity of working together with the same employees is something that I've observed definitely has an impact on provider productivity in health centers. But patient continuity with their provider is interrupted, so that hurts quality. It also hurts efficiency. We have a slide on that to analyze that. New providers, it's great if we're able to bring them in, but you've got your own setup. You might be on an EHR that they haven't used before, so taking time to learn that EHR, number one, and then taking time to I don't want to go as far as to use the word master, but I guess that's the word I'm thinking of. Master that EHR takes even longer time, so that's going to impact their productivity, right? That there's a ramp-up period for new providers. And then lastly, we might lose patients. Many health center patients are more loyal to the provider than they are to the health center per se, so that if that provider were to leave, that patient might seek their care elsewhere. So, which again could lead to less revenue potentially, or losing an established patient and having to replace them with a new patient. There can be a financial impact of that as well. There's probably some other factors. If someone wants to ask questions about those other factors, certainly feel free to. But there's probably other factors too that drive the bottom line. Okay, so here is the impact of vacancies writ out in financial numbers. So there's two columns here, the current and provider vacancies under PPS. PPS is the prospective payment system, which is how we get paid for Medicare and Medicaid. And so we're not going to go into the details of PPS, but it just shows under our current reimbursement system, what is the impact of provider vacancies. So let's say in column 1, we have 10 providers, or maybe that's even our budget or goal or staffing, 10 provider FTEs. An FTE is a full-time equivalent. As most of you know, it's harder and harder to get a full-time provider, right? It's hard to get a provider who wants to work 40 hours a week. So when we look at all of our numbers, we need to say, okay, if there's 2,080 hours in a work year, how many hours did this person work? And if they worked 1,040 because they were, spend time at another healthcare organization or whatever, they're only 0.5 or half of an FTE. So let's look at our current scenario and then compare that to if we're missing 2 providers. So let's say the provider productivity measured in visits per full-time equivalent per year is 3,900. That's not suggesting that's a benchmark or a right number, and if you're not at that number, you're wrong. It's just what this health center might be at, and we're going to hold that number constant. When we only have 8 providers then, instead of 10 providers, so when we have 10 providers averaging 3,900 per visit, we're doing 39,000 visits. When we only have 8 providers at the same productivity, we can only see 31,200 visits. Let's say that the average visits per patient per year, that's PPPY, is 3.0. That means in the current scenario, with the 10 providers, we're able to see 13,000 patients. If we have vacancies, maybe we're only able to see 10,400 patients, right? So when I talked before about the access, that might be a way of measuring the access. Provider panel size is going to be more important later to compare it against, but this is just how many patients are assigned to a particular provider. In this case, it's 1,300, which is, again, not outside the norm. This health center's net revenue per visit is $120, so that means it's kind of like a blended rate when you take in Medicare and Medicaid and self-pay and commercial. This is on average how much they collect for each visit. So when we have 39,000 visits times 120, we're bringing in $4.68 million in revenue. When we're only doing 31,200, we're bringing in only $3.7 million of revenue. So a significant loss in revenue, right? That you can see there, 900,000 plus. The grant revenue doesn't change, right? Because it's a you know, a lot of our grants are fixed. A lot of our contracts aren't going to change if we're getting contributions or whatever. Those are not dependent on the number of visits we do. Then if we look at the expense side, again, remember we talked about that most of the expense is people. So we have less providers, so we're paying less in provider compensation. We also maybe have less variable staff like MAs and that sort of thing, but it's most health centers don't say, well, a provider left and I haven't been able to replace them yet, so I'm going to get rid of an MA. While they are variable, I'm not sure it's immediately flexible. If you look further down on the page, variable OTPS, that's other than the personnel services, so that might be your supplies and things. That number goes down, but fixed stays the same. So this health center, while at the same level of productivity and the same payer mix and everything else, had a profit of $50,000 when they're fully staffed, had a significant loss of $1.7, $1.8 million from provider vacancies. So it has a real impact on the bottom line. Okay. Here's where, for non-financial people, here's why your CFO gets so excited about productivity. So let's say that providers, either a provider or all of your providers, do 100 more visits a year, okay? That would be, we'd say that's a marginal productivity, right? Not that productivity is marginal, it's productivity added on to the margin. So let's say over the course of the year, they did 100 more visits. And I'm not going to say it's easy to do 100 more visits, but if you think about, you know, 200 days, 180 clinic days a year, that's an additional patient on average every other day. So our net revenue for this health center is $120 a visit. So $120 times those 100 visits is $12,000 of additional revenue. We're doing this with a fixed resource, right? If we grow by 10,000 visits, we probably got to hire another provider. If we grow by 100 visits, we don't need to hire another provider. We don't need to hire another MA. So that number is going to stay constant, and so the change in provider and staff salary is going to be zero. Again, not the next session, but the section after that, we are going to talk about incentive compensation. So let's say the health center had a real rudimentary model that says, for any amount over 3,900, we're going to give you $40 a visit, right? We're going to kind of, you know, incentivize you for that way. So 40 times 100 is 4,000 in expense. Our medical supplies are highly variable. Our outside contracted lab is highly variable on number of patients. I know it's potentially on number of self-pay patients, but variable nonetheless. So we have in total 4,900 of additional expenses. We have $12,000 of additional revenue. So it's $7,000 increase in the bottom line. So our bottom line is very, very sensitive to provider productivity. And this is why you've talked about a lot. And that's why when we do the incentive comp session, a lot of it is going to be focused on how do we take care of our star performers or our more productive providers. Okay, so this is a slide originally that I had done. I do a lot of presentations for the National Association of Community Health Centers, and one of the participants was so jazzed up that he created it for his own health center. So this shows the cost of replacing a provider. Again, not something that you're going to have on your financial statements, but a real cost nonetheless. So I estimated, so he put NAC in his analysis. It's not something NAC did, it's something I did for NAC. Of 10,000, I put in $10,000. He said, no, I'm paying like 25 grand. We have both estimated it takes on average 3.5 months to bring in a new provider. I know for some of you, it's even longer than that. So that's problematic. I used in my model 3,600 visits per FTE per year. He said my actual was 3,500. So in those 3.5 months, let's say in the CHC model, they're going to lose 1,021 visits. Their average net revenue per visit is $134, $135. So they're going to lose $137,000 in revenue. They pay their providers on average $195,000, $196,000 with 25% fringe. And so the cost that they don't have, since the provider's not on staff for that month, so that's a cost savings, I guess one would say, or reduction in cost is $69,686. And so the marginal cost, again, this is an economic term, so revenue loss divided by direct compensation is $67,000, right? So that's, as I said before, you know, coverage of overhead, that's $68,000 less to cover overhead. In addition, we probably need to count the lost visits, so we're going to lose some visits also from being lower productivity for a while. He pointed out to me, the CEO, you know what, Curt, even when I can recruit a provider, sometimes it takes me a long time to get them credentialed, and the credentialing is not retroactive. So these numbers might change for you, but you know, it's definitely lost revenue. Okay, sorry, I'm going to go back up. So Clinicians for the Underserved has built a wonderful model. And I put the link to it here for doing this in much, much more detail. And so I would really recommend that all of you run this. You can change the variables. You can see there's and this is not instructions on how to use it. You can put it in you can put in an input variable, or they've kind of pre-populated it with some numbers, and you can say, well, I don't have that exact number. Let me just run the estimate. And so this is a much more, this is only a slice, by the way, of the total tool. So I really recommend all of you look at that to give you a good sense of what it costs when we turn over a provider. Okay. One of the things they'll talk about is, so first, the last bullet first, when we talk about our providers, you know, I'll just say the more time providers spend seeing patients, the more patients they see. This is more compensation or provider staffing, so not necessarily in operations. What health centers are telling me now, though, to look at those first two bullets is, and I'm going to come out of the finance world, so inventory of excess provider FTEs is probably not a great term. What that is the term I hear used more is a float pool, to say we know somebody's going to be leaving. So what we're going to do is we're going to hire ahead of budget. So even if we have 10 providers and we're fully staffed, we find a good provider, we're going to hire that 11th provider, because maybe by the time we get them on and up and running, maybe we will be without a provider if everyone stays, which would be great. That float provider could cover when a provider calls out sick or when they're on vacation, or, you know, so really a strategy of getting ahead of that 3.5 month cycle might make sense. And certainly when I talked about investments, that's an investment I almost always see pay off in some sort of float pool. Just to manage your expectations, the way the float pool typically ends up working is, rather than covering absences and floating around to sites, usually what it does is just make sure you don't have vacancies. And so by the time that float provider comes on, someone else is left, and it's just a more aggressive hiring policy that helps, avoid or limit vacancies. Provider consistency. So this is what I talked about when this kind of continuity of care, we try to have this goal of same providers, same exam rooms, same support staff. That really impacts provider productivity. And I will tell you, what I don't have here is a provider satisfaction, right? When we talk about all this, what I always like to say is, what we would say on the finance side is, doing this, if I pay the provider more, if I give them another half MA, if I don't move them around from site to site, how less likely does that make them to quit? Your CFO would love to quantify that. It's probably not quantifiable, but we know that a lot of times providers leave because they're frustrated with the way you run the health center. So maybe they could make money more, but making them happy is also important. So trying to maintain and then having that turnover, even if we're using like a part-time or a locum provider, that hurts that provider consistency. Here's an example from the RVU system, which is the relative value units, which basically is a way of measuring the intensity of health center services. A 99203, and I know that, a coder would look at these and say, well, a 99203 is not the same service as a 99213, but they're kind of the middle visit for both a new, that being the 99203, and as well as an established patient. So using the RVU system, if we had a cost per review of $60, the cost for a 99203 for a health center might be $188. We know for our patients who are eligible for so many programs, they're not just bringing in an insurance card, it's probably another 3 hours that your administrative staff need to spend to get them up and running. So a visit for them might be $248, whereas a visit for an established patient might be $126. So that new patient visit costs twice as much as the established patient visit. So when I talked about continuity of care and patients leaving and turning over patients, here's the cost. Again, not a cost that you're going to see as a line item in your financial statements, but definitely a cost for the organization. Okay, so a little bit of the future. So one of our points of the future is we're supposed to be aiming towards the triple aim, which looks to, I don't know if reduce, but slow the increase of total cost of care per patient, improving health of populations, and improving the patient experience, with the recognition that in the United States, we have the world's most expensive healthcare system, and we have some of the worst outcomes. So not something that policymakers are real happy with. I'll also note sometimes you do hear about the quadruple aim, the fourth aim being provider satisfaction and retention. That's what we're talking about here, so I didn't feel the need to add it to our diagram. Obviously, we're talking about addressing it right now. So one of the things that we talk about is practice transformation in the APM, and this slide, I like to explain it this way, and then we'll talk about the concept of supply and demand. So in 1972, the best-selling car in the United States was the Chevy Impala, a large gas-guzzling car. I don't even know how many miles it got to the gallon, probably not very many. And then in 1973, there was trouble in the Middle East. There's kind of always trouble in the Middle East, but in this one, they stopped sending us oil. And so the price of gas, I remember I was living in Ohio at the time, and where I live, the price of gas went from, I think, 34 cents a gallon to about $1 a gallon. So big increase. So less supply, big increase in price. So then in 1974, The national speed limit was actually 70 miles per hour. They lowered it to 55. I know where many of you live, the speed limit is now 85 miles an hour. But this happened back then, and this shows my point. So by 1982, a scant 10 years later, the best-selling car in America was the Ford Escort, a much smaller car, as you can see, a car that used less gas. So what finance and economics would say is we follow the law of supply and demand. If something is in short supply and thus becomes expensive, the market learns to get by with less of it. And I feel like we may have reached that point with providers by 2019, that they are expensive in short supply now, and I guess I would say expensive and in short supply in the foreseeable future. So to me, patient-centered medical home, I know it has a lot of different meanings. To me, patient-centered medical home is how can we shift work from the first two lines to any of the other lines, right? So how can we add staff that take away work from our providers? It might also make our providers happy or happier to say, you know, I'm doing a lot of work that didn't require me to go to medical school. So if you give me another MA and that MA spends a lot of their time filling out forms, you know, I don't want to say, they'll say I'm less likely to quit, but, you know, I'll be happier and I'll be more satisfied here at the health center. Over time, what we might see is the number of visits per patient going down and touches, that is, let's think about that as maybe some of the other things on UDS Table 5, other encounters with other staff increasing. We can't really make that work in the PPS model. So here we've seen that I've shown the red things that are highlighted are the things that change. So maybe we can lower visits per patient per year from 3.0 to 2.9 by having other staff. But if we do the same number of visits, we have that same $4.68 million of patient service revenue. We've added that variable staff compensation of $200,000. So we lose money with practice transformation under the PPS system, right? We tend to add staff and add staffing expense faster than we add to revenue. That's why we're looking at alternative payment methodologies. So let's say we can double down on this model and add another, look in the last column, $1.5 million of variable staff. Maybe we can lower that number to 2.8 visits per patient per year. Maybe we can increase panel size, and maybe we get paid that blue number on a per patient basis rather than a per member basis, so that in the last column you can see the patient service revenue going up, right? So that's a change in the model. That's what our future might look like. I've done a lot of work in the state of Oregon, and this is actually what happened in the state of Oregon. So you can see the bottom line impact of this is a way to make the patient-centered medical home or practice transformation affordable. And one last scenario, even with our vacancies then, if we're short on providers, and we can really then say we're always going to be short on providers, if we shift even more work and that visits per patient per year goes down to 2.7, if we have a different way of getting paid, maybe we can make this work, and maybe it can help mitigate some of the financial impact of provider shortages in changing the model. The point here, and I know I'm getting way ahead of you know, maybe the intent of just provider compensation, is this shift in the model, although we'd like to do it given market forces, really works best when we're under an alternative payment methodology. So we did want to leave the last 5 minutes for questions. I've put my contact information there if you want to email me any questions. But Mariah, do we want to open the line for questions, or certainly you can type them into the chat?
Sure. Thank you again for that presentation, Curt. And everybody, I just want to let you know we're going to keep you muted just to cut down on some potential background noise. But you're absolutely more than welcome to chime into the questions box. Just if you've got anything, burning questions right now, feel free to type them in. If nothing's coming to you right now, but you just want to think about it, something comes to you a little bit later, feel free to email Curt. His information is listed on the screen there, or you can reach out to anybody at the STAR Center, and we'll do our best to connect you with the correct information. We did have one question come in just now. What does APM stand for?
Okay. APM stands for Alternative Payment Methodology. So the PPS is actually federal legislation that was introduced. It introduced in 99 or 2000, and the system started in 2001. So it stands for Alternative Payment Methodology. So the state, your state Medicaid agency is allowed to apply to CMS, the Center for Medicare and Medicaid Services, for a waiver to pick a different way to pay FQHCs. As most of you probably know, the FQHCs and community health centers have a protected federal benefit of getting that rate. We want to put there. Hi there, I am sending a message from the largest, oldest FQHC in WNY. Is that Western New York? I really enjoyed the presentation. Can you touch base on resources you have for provider recruiting? I think if you email me that, if you're asking for like recruiters or, you know, there's various other agencies that have, you know, recruitment, job posting sites and things like that, we can do that. I think, would that be fair, Mariah, to say between you and I, we could supply those resources?
Absolutely, yeah. I think between our teams, we've probably got you covered.
Yep, okay. Yes, it is Western New York, okay. My father grew up in Gowanda. That's why I was able to guess that. So.
All right. Well, it looks like we are getting close to the end of our hour here. Aren't seeing any more questions coming in just yet, so I'm just going to give you my little rundown of our closing housekeeping. Again, if you have any questions, you can keep putting them in the chat box and we'll follow up with you individually, or you can send us an email. We'll be sending out the slides and recording probably tomorrow morning with links to all of that in an email to everybody who's registered today. And we'll look forward to having everybody back with us for our next session on Wednesday, May 15th at 1 p.m. Eastern. If there are no more questions on the line, I think I'll give you your 2 minutes back, everybody. And thank you for joining us, and we'll see you next week. Have a good one.
Okay, thanks, everyone.